Welcome to The Virtual Shift, a show looking at the seismic changes happening in healthcare with virtual care at the epicenter. Join me and my guests as we look at key cultural and policy shifts impacting how providers, payers, and patients connect, as well as how care is being reimagined both for today and the future. Hello, and thanks for tuning in today. I'm your host, Tom Foley. You can learn more about this show by visiting the program on healthcarenowradio.com, and be sure to follow me on LinkedIn, Twitter at FoleyTom, and the hashtag The Virtual Shift. Today we have a great guest on, Jamie Hall. He is the president and CEO of CirrusMD. Jamie, welcome to the program.
Well, Tom, thanks for having me. I've been enjoying your podcast, and it's great to be on with you.
Awesome. First, I have a big question for you.
Sure.
Michigan number 2 football. I know you're a Michigan grad, so I thought I'd just pop in a little bit on what's going on there.
I'm not going to jinx anything. I'm just quiet about it until after the Ohio State game. That's the only thing.
Exactly. It'll be a great end to the season. I hope you don't mind the little bit of humor there. I follow Michigan State myself.
Not at all. Don't get me started on that. We'll burn up the whole hour.
Yeah. So you guys have done great things. Tell us a little bit about the organization and what you're doing.
Yeah, sure. So CirrusMD is a virtual health organization. We've been around for almost 10 years, and today we serve 10 million members across all 50 states. We're available 24/7, 365, and we serve our customers are generally commercial, large self-insured employers and payers. We serve Medicaid populations through managed Medicaid, and it's our great privilege to serve around 5 million of our veterans through our relationship with the VA.
Awesome. Yeah, that is awesome. I didn't know you had the working with the veterans. I worked for Cerner for a while on the VA project, so very familiar with that effort. And congrats and thank you for serving our veterans. So you just recently announced a new care and guidance program called Physician First Care and Guidance. Tell us a little bit about what that program's about.
Yeah, so, well, first let me just start by telling you a little bit about how we deliver our traditional solution, and then I'll build on that with Physician First Care and Guidance, if that's okay, just to create some context.
Sure. Go for it.
So what's really different and unique about CirrusMD is that we meet our patients via chat as the first mode of communication, and we meet them in under 60 seconds. Actually, Tom, on average, it's about 15 seconds from the time that a patient says, ouch, that hurts or that looks weird, to there's actually a real doctor. It's not a bot, it's not a triage tool. They actually, a real physician is texting back and saying, I'm here, how can I help you? We think first and foremost, that's really important. And secondarily, we keep our encounter windows open for 7 days. So there's no pressure on the physicians or on the patients to speed through an encounter, which I think creates a much deeper, much richer relationship. On average, our encounters are about 20 minutes, but pulling off the time constraints, we think helps a lot. And what it leads to is really effective, efficient, and empathetic care. So, 95% of the care that comes onto our platform via chat actually goes all the way through and ends via chat without switching to video, without switching to audio, things like that. Although all of those modalities are available. And it's super effective. 83% of what comes through our virtual front door is actually handled on the platform. So it doesn't need to go then to in-person care. But when you think about that element, that the rest of it that has to go to in-person care, that's really expensive healthcare. That's going to the home, that's going to a clinic, that's going to a hospital. And we feel that, one of the traditional problems with virtual care is it stood alone. Aside, not fully integrated with all of the other settings of care. So what Physician First Care and Guidance seeks to do is first leverage a couple things that we do already today. One is we meet a patient at their moment of need. So there's, we're all fathers or leaders or athletes or whatever it is that we are during our lives and what we think of ourselves as, but we're not patients unless we absolutely have to be. But the moment that we turn ourselves into a patient, that we say, hey, we need help, we're there in seconds. We're not there a week, 2 weeks, a month, 2 months later when you finally get an appointment. We're there when the patient is most activated. The second is we meet that patient with a physician. It's not an RN. It's not a non-clinical navigator. It's not some sort of a triage tool. It's actually a doctor. And we know that doctors are an authority figure, but they come with trust. So we're meeting that person who's highly activated with a doctor who's inherently trusted. And then what we have built into our platform is a way to surface risk that may not be the chief complaint, the chief reason that a patient came in. So we're mining information that we have on our platform to surface up, what else might be going on. Because we know, even though, we have hundreds of thousands of patients come through our virtual front door every day, but we know that half of them are pre-diabetic or living with type 2 diabetes. We know that half of them have an MSK issue that probably should be looked at clinically. We know that many of them are dealing with stress, anxiety, and depression. So the question is, how do you find that and engage it? And we think this medium of chat, first and foremost, is great because there's a degree of anonymity associated with it. By removing the time, it gives patients and doctors to talk a little bit more, but what's really driving it is our clinical intelligence engine, which is surfacing in context and in workflow for the physician risk associated with the patient. And then the really unique thing that we're doing is we're digging into that person at a member level at their employer, their health plan, and pulling up benefits that may be associated with that risk. So I may come in for a chest cold. We may realize that I'm somebody living with type 2 diabetes, and a physician might say, hey, Jamie, about your diabetes, how is that going? I might say, well, I'm struggling. And they might say, do you know your employer has a solution like Livongo, for example, that's available and free to you? I'm going to drop it into the chat. I'd love you to check it out, and I'll check in with you a couple of days and see how that's going. So we think that's new and different and super exciting. The other thing that we're doing is then directing people to brick and mortar care at the home, in a clinic or at a hospital, and doing that through a lens of cost and quality. So, hey, Jamie, you need to see an orthopedist in Lafayette, California. Here are the best 3 orthopedists in your area. I'm going to drop them into the chat. So that's what we're doing. We're trying to combine the best of virtual care, make it more accessible, super empathetic, take some of the time constraints off of it, but then add access to benefits, which we all forget about, right after we've signed up for them, and then in setting really high quality providers that people can go see in person.
It's interesting. So you're having this chat between a doctor and a patient. If that quote unquote chat was taking place in person inside of an exam room, you'd have an EHR there, and the doctor would probably have his fingers on that, him or her will have that fingers on the keyboard, and that chat is going to be more clinically oriented versus more social determinants of health oriented, I would argue, because you're trying to mine that patient and trying to find that root cause of it's not about X, it's really about Y and Z, and X is the symptom, if you will, right? Is that fair?
Yeah.
So do you guys do you use an EHR, or how do you create that medical record in the context of that encounter?
Yeah, so we built our own EHR, which is purpose built for this type of interaction with a patient. EHRs have sort of started as a billing tool and repurposed as a physician-patient tool. And I'll just give you one of my own examples. Recently, after COVID, my first visit to see a primary care doctor, I was lucky to get into the great doctor out here, and it took me 2 months to get an appointment. I finally got in, and for the 10 to 15 minutes I was there, he had his back to me the whole time, and he was typing in, my family medical history into his EHR. It was really dissatisfying visit. Ours is built in order to consume information, and the thing is, there's a lot of patient information available through these HMS designated HIEs. So we may be meeting you for the first time, but we'll know a lot about chronic conditions, labs, other things that you have going on associated with your health. And it's designed to give the doctor just what they need when they need it based on the chat. So think about this for a second, Tom, because we're working on unstructured data, we can train these new tools that we all have, generative AI tools, to listen to the chat while it's going on. So we have 50 million chats between physicians and patients that we can use to train our AI models on. So the the way that we set it up is instead of having a bot out in front of the physician triaging away smaller things, because we think those smaller things are important, that we know that half of those people have something that's going on from a chronic condition standpoint. We want them to engage with a physician. We think that's super leverage, it's special, and it's an opportunity. But we put our AI sort of on the shoulder of the doctor to listen and say, hey, Jamie just said that he used to manage his stress by running, but he can't because his knee hurts. That might be an MSK issue. And Jamie has, Hinge Health for his MSK provider through his employer. That's new and that's different. And we think that that's going to be much more effective. So, it's hard to do. And a lot of even the virtual visits that happen in traditional telehealth, really what you're doing is you're just replicating an in-person visit where I'm sitting here and I'm staring at a doctor having a one-on-one conversation. The doctor really can't do a lot else unless they look away from me. In chat, the physician can really get a lot more information while they're chatting with the patient. So yeah, it's different. I would say that it's purpose-built. We think about how do you optimize for virtual health? How do we actually pull it into the mainstream? This is one of the things that we're doing that we think is value that can't be created in another setting.
Very interesting and quite compelling, I might add. So the critical point about the continuity of care is, yes, virtual care has its place, and you seem to be changing the dynamics as to what defines virtual care in a very elegant way, as you've already articulated. How do you transition the care? If you talked earlier about going to a brick and mortar, how does that record follow that patient into that brick and mortar setting if you're not the platform of choice in that setting?
Yeah, there are a number of different ways, and the one is that what everybody else does, you can work with health systems and build pipes into their EHRs. I think that's sort of a zero sum game because it just every one version of Epic is one version of Epic, and it's a hard thing to do. What's really helpful is, and back 10 years ago when I was first looking at these health information exchanges, the promise was great, but the data wasn't there. Now that they've sort of centralized down to 5, I think they're TEFCA HIEs, we find that almost every patient that comes through, we have diagnosis data on them, we have gaps in care data on them, we have labs associated with them. So because that is pushing and pulling data from most of the big EHRs across the country, when we update a patient's record, it gets automatically updated into their EHR. So that's a really elegant way, if it works, that's a really elegant way of doing it where we don't have to build, everybody's contributing to the same centralized data warehouse. And I really like that model. But here's the other thing is that, again, think about the way that we're interacting with our patients. It's chat. So on the patient's phone, they have a word-for-word transcript of everything that's happened with that provider. They also have a summary at the end. And so, this is another problem in healthcare. We listen to our doctors and then we walk out of the treatment room and we go, what the heck, did they say ice it or heat it or ice and then heat? I don't know, I can't remember, but it's all right there. And so they can walk into any other point of care and say, here's exactly what happened when I talked to the physician at CirrusMD. So I think we're getting to a place where that sort of portability of a patient record is going to be much more frictionless. We're not totally there yet, but there are a couple of ways to skin that cat.
Yeah, and you're absolutely correct. I think the stat is after 1 hour post visit, 50% of the patient starts to forget what the doctor actually said, right? And then the other stat relative to that is 30 to 50%, depending on the study that you read, never fill their scripts. So I've gone through all this clinical encounter and engaged the provider. I got the answer, take your meds, and I don't take my meds, or I forget, and therefore I don't engage further, right? It's a very challenging delivery of care. Sometimes I think it's not the system that's broke, it's the way in which patients engage or elect to engage, right? I think Chris Chen from ChenMed said in a quote, 77%, I could get it wrong, I interviewed him a couple months ago, 77% of all outcomes are behavioral based, right? Mm-hmm. It's what happens when you're in the home, or Am I dieting? Am I exercising? Am I taking my meds? Am I doing what the doctor says? And the answer is no, 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 and no. Right. So how do we get to a better state of healthcare? And I sense what you're doing is you're modernizing healthcare to the degree that chat is kind of a new thing. It's not a new thing, but it's a new thing in healthcare in the context of how do I engage my provider in a virtual setting, record that, and have that record so that everybody's clear on what was said, what wasn't said, and what you should do and what you shouldn't do. Very compelling. If you don't mind, I'd like to come back to this data because that's another very compelling approach. So I have like Commonwealth in my head, care quality in my head. Are you saying that you will actually go while the patient's in chat, if you will, you can query them and bring their health records into the system and have a full display of what all their history, no matter where they've been, right? Whether they're from New Jersey or a snowbird in Florida.
Yeah, that's exactly right. And one of the, when we think about these new tools, we can't have a conversation without talking about AI or generative AI, but when we think about what do these tools do for us in the way that we want to deliver care, where it's always a human interaction, a physician and a patient, the same tooling that we use to go and pluck out a benefit that's relevant to a health, issue that I'm talking about with a physician. I'm talking about stress and anxiety, and it surfaces, hey, I've got Spring Health, for example, available to me. That same tooling can go and, pull up the most salient element. The thing about those health records is everything's there. I'm not a spring chicken anymore, so I've got a whole lifetime of health records. So, what are the things that are important? Where are the gaps in my care that need to be closed? Those sorts of things. So we can be smart about surfacing just what the physician needs. And the other key part of that is just when they need it. So we're getting it into the conversation flow so a doctor can look over and say, it's just giving them the opportunity to have information. And then it's up to the physician. We really believe we have our own doctors. We pay them hourly. We're not fee for service. So there's no, again, rush to get through healthcare, but we have built this so that they have information that they need exactly when they need it, no more, no less. But then it's up to their skill, their training, their human empathy to decide, is this appropriate for me to bring into the conversation with the patient, or do I not?
And you're bringing up so many valid points, and you do change the approach of virtual care because it's typically I'll just call it a once and done engagement, right? Just like to some degrees in a fee for service model, I'm in that provider's exam room for 10, 15 minutes at most on average, and when you leave, there's no continuity. I mean, right? So, and when you leave, it's more so when you leave that telehealth session, there's no follow up, right? Yeah. And there's little ability on how to move that data from that engagement to your primary or your cardiologist or your other specialties that you might have because you have multiple chronic conditions. The point is that there's an approach where you I always say either you're just going to skim off the top, right? Mm-hmm. Because it's profitable to do that, or you're going to integrate. And I think this is where CirrusMD is, where you're going to provide greater engagement and more quality engagement in the process and connect you to the next in line, if you will, from a continuity of care perspective. So there's no gaps in care. Everybody knows it. Great job. I've studied a lot of models, and I'm impressed for sure.
I would say I would just quickly add to that. So this is something that we think about a lot at CirrusMD. We are living in a time when we have, despite all of us in the industry, our best efforts, healthcare is getting more costly, more confusing, less accessible than ever. At the same time, we're losing primary care doctors at an unsustainable rate in the U.S. So the question is, do we ration access to primary care doctors that we have. And I think that's our approach generally as an industry. We have digital tools and non-clinical navigators and helpers, and then lower level clinical folks, and then you finally get to a doctor. We think that causes a lot of friction for a patient, and it causes a lot of waste. We think if you just think about this, if every healthcare journey, whether it's as short as a chest cold or as long as somebody living with polychronic conditions, started with a simple chat with the doctor, started them off, first of all, with the influence of a physician to take the right, best next step, but also on a clinical pathway that's prescribed by a physician. So we try to do that. And then, more and more people, over half the people in the US, don't have a primary care physician. Either it's their financial or geographic barriers, or it's just inconvenient. More and more, we are treating people as their primary care physician. And 50% of the people who use us once, who may come in for an episodic thing, use us again and again. In a commercial population, in a Medicaid population, it's 70%. So we think that that's something to build on.
Absolutely, and you're right. We have an older, ager, sicker, a growing older, ager, sicker population, less doctors and nurses. To me, that is the problem. My audience knows that the other half of that problem is the average Medicare patient, 5 chronic conditions, sees 9 different doctors, only in front of their doctors 15 hours in a given year in total. The biggest question, and what I call the gap in care, is what happens the other 8,745 hours. That's where care wellness is achieved, and that's where we have to find our way to make it easier to come out of that environment and into healthcare. And to your point, having a simple chat, a simple but powerful chat with a doctor in an environment that the patient's comfortable in, kind of opens up the conversation to learn more, versus being there's always a lot of tenseness, if you will, when you're in that exam room, and you're not going to learn as much because the doctor, again, is got to get in and out, right?
No, that's
12
right.
minutes at best. So.
Yeah, that's absolutely right, and that's why we thought it was so important. You're absolutely right. Even in primary care, it's less than that. You're talking about the folks who really use the healthcare system. The majority of us, we're rarely in front of an actual doctor. But when we uniquely connect a patient really quickly and efficiently with a doctor, let's arm the doctor with the tools to push the patient back to the next best step. So if it's about wellness, most employers these days have really well thought through wellness programs to try to keep their employees healthy and happy. If it's one thing, if your employer's person calls up and says, "Hey, or you get a email or a text or snail mail to your home, and you kind of throw it away, and you're like, I don't really care about that." If your doctor says, "Hey, Tom, your employer has this resource available to you, I'd like you to try it," my guess is you're more likely to try it than not. And we're playing out that thesis in real time.
Yeah, and I from our earlier conversation, it sounds like you're getting a lot of positive results, and that's what it's all about. Finding different ways to engage a patient in the comfort that they're willing to engage will always produce greater outcomes. And my hat's off to you for thinking outside that box, and not having and not replicating something that everybody else has been doing. So congratulations on that front. So what's coming down the road for CirrusMD? Obviously, you had this great launch, making some great strides, serving our military for sure. What do you see the next year or two for not only CirrusMD, but the market as a whole?
Well, I think first and foremost, we literally launched Physician First Care and Guidance on the 4th of October, so we're a little over a month into it, and our whole focus is on bringing this to our customers, bringing this to our prospects, and across a number of different verticals. So that's where the company's focused. But we all believe that we're just scratching the surface, and the work that it takes is thoughtfully thinking about how do we reassemble care using all of the tools that we have to our disposal, the ones that most work to optimize for the physician, for the patient, and then for the plan sponsor, whoever's paying for it, and remove those things that are barriers or friction in the path of care. And again, we're finding as we're talking about this in market, I just had a customer this morning who was like, you know what, this could help me with my risk adjustment scores. If you could find those gaps, if you could intercept a patient at the point of care, either close that gap or send the patient with the gap, get them to one of our in-network physicians, that would be great. So I think that once we get rolling, there's going to be lots and lots of new things that we can do. I also think we haven't even started to really mine the behavioral health aspects of chat. So this degree of people who chat are chatty. They're really chatty. And it's great because our doctors have lots of time to just text back and forth with the patient. And what that does is it starts to reveal more and more information. It creates a richer, you'd be surprised at how, our patient sat scores are in the 96th percentile. They love to engage with our doctors. And we don't have a primary care shortage at CirrusMD. We have people knocking on our door because our physicians have an 80 net promoter score as employees. They love this way of engaging because they're not forced to race from patient to patient. We give them the time, we give them the tools, we give them the information to practice the way that they wanted to. So again, I think there's lots. What it's going to be, right now we're trying to keep the organization focused for the next 12 months or so, but we'll be building on this concept.
Awesome. Well, you're always welcome to come back. Always a pleasure speaking with you. Jamie Hall, President and CEO of CirrusMD. Thanks again for joining the program.
Thanks so much, Tom. Really appreciate it.
That's today's shift. I appreciate the audience taking the time to tune in. If you missed part of today's episode, you can tune back in at the healthcarenowradio.com at the same time, 11 a.m. or 7 p.m. Eastern throughout the week. And be sure to check out the program page at thevirtualshift.co. As well, remember to follow me on LinkedIn, Twitter at FoleyTom, and follow the show's hashtag, TheVirtualShift. I'm Tom Foley. Until the next shift.